slide, as always, an impact slide. I want you to pay attention to that. And says spot the difference. And then you can obviously see two scenarios over here. I can assure you there are different men and different women. It's not the same person carrying whosoever always. So there are two different scenarios over here. I want you to pay attention, especially to the female here in this case. And if you can come up and just visualize what possibly could be a difference between this woman over here as compared to one over here. Of course, both of them look sick. They are alive. So especially I want you to look at these parts. I want you to compare, for example, her hand over here, the curvature of her spine over here, her face, if you can probably see it, maybe in presentation would be better, and then the heels. And also pay attention to, again, the posture at the back over here, her hand, her chin, her face, and again, her leg. So these are some of the important things I'm going to discuss today for you to pay attention. And again, as I said earlier, both of you who are, all of you who are visual learners would pick up some information from there and compare and contrast. Okay. Now, today's picture basically focuses on this particular scenario, and I'm going to expand on that. But the other one was comparison. It will come later. Now, this is a classical picture. The picture that I showed you was the classical textbook picture of tetanus. That's what it was. And you can see from here, go over here, you can see her clenched fist. She was fully conscious. Laryngospasm of the larynx. Opisthotonus. Opisthotonus is a position where you kind of bend backwards instead of bending forward. It's called opisthotonus position. And then again, you can also see a very minor wound over here. I think the whole point I've been trying to emphasize upon you for the last couple of days is that some of the injuries are very minor, but they have a huge impact. So don't think any kind of prick, any kind of a smaller injury is by all means not a minor. It could end up in a major catastrophe. And the other important thing is a surgical emergency. So it's a preventable. So this means if this person could carry her in time to hospital, of course, this is not a sequence of 911 call. You can guess from here. It's some impoverished areas, and those people, their problem is much, and you can see the problems over here. The poor gentleman has to carry her to the hospital. Now, the whole scenario is tied up with clostridia. So we're going to discuss an important bacteria, clostridia. There are many different types of that, but the most important I will discuss today among the family is called fringens, tetani, botulinum, and difficile. So these are the important four clostridia that we will discuss today. Clostridia as a family, remember we started with the bigger family. They are ubiquitous, meaning they are present everywhere. They are in soil, water, sewage, and the interesting part is, as I've been trying to emphasize over and over again on you, is that they are part of normal microbial flora in gastrointestinal tract of animals and humans. Right? So this is normal gastrointestinal tract. Staph and strep were gram-positive cocci, and these are rods. So they are gram-positive rods, and mostly by far are harmless saprophytes, other than the four I just mentioned. But some of them are well-recognized human pathogens because, for example, Clostridium tetani causes tetanus. Clostridium botulinum causes botulism. It's a disease. Perfringen causes gas gangrene. The other name for gas gangrene is myonecrosis. And both perfringens and Difficile cause diarrhea and colitis. So they are associated with human disease. When they are associated with human disease, they are considered as human pathogens. Now, the other important thing for the family is today we see a lot of skin and soft tissue infections. That's what you saw. They're also important for food poisoning. I'm going to discuss that in antibiotic-associated diarrhea. That's also a very important question you always expect in all different forms. Colitis, inflammation of colon. So why do they cause disease? Why do they cause disease? Because they have those virulence factors. And some of the virulence factors they have is that they have an ability to survive in adverse condition. They form spore. So these are spore-forming bacteria. They grow rapidly in nutritionally enriched and oxygen-deprived environment. They don't like oxygen. So that would tell you that they would love to grow on dead tissue. That's why we have to remove dead tissue. Yesterday I was talking about, you saw that debridement on that person. So that's the other name. The media give that name as a flesh-eating bacteria. So that yesterday one step was a flesh-eating bacteria, especially the one that's pyogenes, because it's going to eat the flesh and then you have to remove the flesh. It has numerous toxins which are histolytic, mean breaking histology of the skin and the tissue. It has enterotoxin, is a neurotoxin. As the name suggests, neurotoxins will have effect on central nervous system, enterotoxin will have effect on intestine, and histolytic toxin will have effect on the tissue structure and histology. So let's go for the first one. Again, as I said, we'll just follow the same scheme of 5 major things that I told you as objectives. The first one is biology, virulence, and disease. It grows very rapidly. It has a virulence factor, as we saw, many toxins and enzymes that lyse blood cells and destroy tissue. If such a virulence factor is to happen, the disease will be sepsis, massive hemolysis, and myonecrosis. So these are the effects of that virulence. They also produce a heat-sensitive enterotoxin that binds to receptor. Remember, we talked about those receptors which are there on the cell surface, and these enterotoxin will bind to them, and then you have watery diarrhea. So what will happen in watery diarrhea is that you lose the electrolytes and fluids. So you have to compensate for the loss of those electrolytes, especially if it's Clostridium perfringens. If you were to stain them under gram stain, you can see from here is a wound specimen, and you will see a typical structure. They are like rods. And then again, sometime you can see over here that they may appear as gram negative, but by far, we consider them as gram-positive rods. So that's more or less like a staining problem that we may come across that should not fool you in considering gram-negative, but gram-negative is even or worse. If you were to grow them on sheep blood agar, you can see they come up as a flat colonies which have hemolytic ability, and then the moment you see that they have a complete hemolysis. What do you call a complete hemolysis? There were 3 types of hemolysis, I said. What is the name of complete hemolysis? Yesterday, right? Beta hemolysis, correct. Beta hemolysis. So beta hemolysis. So this beta hemolysis, which is a complete hemolysis, is caused by a toxin which is called theta toxin. So you can see theta toxin. It does also have a partial hemolysis called by alpha toxin. So alpha toxin is a partial hemolysis, and beta hemolysis. So these are very important questions that clinical are always asked. So keep that in mind. Now, if you look at the disease they cause, especially Clostridium perfringens, very good table from your book, soft tissue infections and gastroenteritis. In soft tissue infection, we have cellulitis, we have suppurative myositis, we have myonecrosis. So myonecrosis is very important because it's very painful. It causes rapid dissection of muscle tissue, and once it spreads systemically, it has a high mortality. We also call it gas gangrene, and that was very common in World War, and especially in soldiers when pre-antibiotic area, when there were no antibiotics. Food poisoning still very common. You get a rapid onset of abdominal cramps. There is a watery diarrhea. There is no fever though. And then you may have necrotizing enteritis. And necrotizing basically means that it is going to cause necrosis of the wall of intestine. And if it does so, this means that it's going to penetrate, be more invasive, and blood will also come in the stool. So you may have bloody diarrhea. And if it punctures the intestine, because of its invasiveness, it's going to cause peritonitis. It's going to go into peritoneum. So these are some of the effects of Clostridium perfringens in terms of the disease they cause. This is cellulitis. You can see from here typical cellulitis. And we saw cellulitis for staph as well and strep as well. The difference is that this one basically is more of after a traumatic injury. The person had a fracture of the tibia, and after 5 days, it develops this kind of skin discoloration, and you can see it's oozing out some of the material over here. And if you were to touch it, you would kind of feel that bubbly thing. That's a dangerous part because it shows that maybe myonecrosis can set in. But if you want to look at the myonecrosis, this is what myonecrosis means. So that's where, when the bacteria penetrates into there, you start producing gas, right? And then again, it's going to cause death tissue. So what they need to do is they have to cut and open it up. Why do they cut and open it up? No, somebody was just saying, yeah, oxygen. Because bacteria doesn't like oxygen. So if you cut it open, provide oxygen, oxygen is going to kill the bacteria. So if you close something, right, the chances are that you are going to allow the bacteria to spread. Okay, so that's a typical, very common for soldiers, World War, no pre-antibiotic area. So all they need to do was cut, amputate. That was a very bad scenario for Clostridium. Still over here, if you, God forbid, have a roadside accident, even if there's a minor scratch, they want to make sure that you have got tetanus toxide in your system. Otherwise, anything can set in. So that's Clostridium tetanus thing that we have to have. As far as epidemiology is concerned, as I said, ubiquitous, present everywhere. And I also told you as a normal intestinal flora. So that's amazing that all these bacteria are normally with us. And there are opportunistic bacteria. They're waiting for time for us to allow them to go, right? So we had abrasion, cut, prick, whatever, and then they would not be your friends. The friends become foes. Type A strains are responsible for most human infection. Soft tissue infection, very common if you were to look at the wounds. Food poisoning, very common in this country, where the meat products are held below temperature 60 degrees C, and this will allow the organism to grow to large numbers. So food poisoning by Clostridium perfringens, especially hotels and restaurants, they're usually checked by FDAs, but you have to be careful. How do you diagnose? Of course, you have to look at the gram staining. They look gram-positive rods, large in size, and they rapidly grow in culture. So that's, again, important thing that you have to intervene ASAP. Otherwise, you're going to allow bacteria to grow and come out of control. How do you treat, prevent? As I said, since they're rapidly dividing, rapid treatment is essential for serious infection. As I said earlier, you have to cut a lot of tissues if the tissue die because they want to grow on dead tissue. We call surgical debridement. You have to give a very high dose of penicillin. And if it happens food poisoning, you have to go symptomatic treatment. You have to make sure that proper wound care is taken place and you have prophylactic antibiotics, which should cover most of the infection in this case. Okay, the second one, which I showed you in the impact slide about the tetanus, is Clostridium tetani. Again, it is very oxygen sensitive, extremely oxygen sensitive, which makes detection by culture difficult. So it's very difficult for us to grow. So how would we grow then? If it's difficult to grow, it's oxygen sensitive, how would you grow then? Correct, anaerobic jar. So you have anaerobic jar, you take the oxygen out and then it will grow. Simple as that. We do have that. As far as the virus is concerned, it has a heat labile neurotoxin, which is called tetanospasmin, right? Tetanospasmin. And what it does is that this tetanospasmin blocks release of neurotransmitter for inhibitory synapses, especially GABA and lysine. So if there is no inhibition of the contraction, the current contraction will go in spasmodic mode. That's what we did in muscle physiology. If you remember that, we talked about tetanospasming, talked about a spasmodic thing, especially for tetanus. Okay, because it messes up the autonomic nervous system. Very important concept, always asked in one form or the other. Be prepared for that. And I'm going to give you some other paralysis, especially for polio virus. You see the difference between two kinds of paralysis. But this one, by all means, is a heat labile neurotoxin, blocks release of inhibitory synapse GABA. And that's gamma aminobutyric acid and glycine. Both of them are inhibitory synapses. And then you get muscle spasm. So in tetanus, you get muscle spasm. So that's what you need to be very careful. As far as diseases are concerned, it may give you a generalized tetanus, where you have generalized muscular spasm. And once it involves autonomic nervous system, it can cause cardiac arrhythmias, a fluctuation in blood pressure, profound sweating and diarrhea, because all your muscles are going to contract. So if muscle starts uncontrolled contraction, you have the typical generalized tetanus. Or you may have a localized tetanus where the injury is. Okay? And the worst form of that will be that if you were to cut the umbilical stump of the baby with the non-sterile knife or scissors, the babies will have neonatal tetanus. And that has had a very high mortality in some of the underdeveloped countries where they don't have a clean knife or clean scissors to cut the umbilical cord after birth. Okay? Now, as far as epidemiology is concerned, they are present everywhere, as I told earlier. Exposure to spore is common, but disease is uncommon, especially because we all been vaccinated. And hopefully we have a good medical care. The risk is greatest for people who do not have vaccine, right? But also remember, very common question asked that many times the disease will give you lifelong immunity, but this disease does not induce immunity. This is one of those diseases that every time you have to have tetanus toxoid, make sure that you're updated with that. So they always give you update charts for that. In these days and culture, what's happening is that we're worried about roadside accidents, but I was reading, in fact, yesterday night and today as well, with the modern, we call it modern medicine, that while dermatologists and medical people are struggling, and we are advocating and pushing on your minds to avoid pinprick and be careful. But at the same time, cultural, sexual, endowment, you name it, is creating an environment where people are going to piercing. We were still fighting for ear piercing, and we're still dealing with the problems that you may get with ear piercing. But it turns out to be today's culture that there's no part of human anatomy that's not been pierced. To such an extent that people can have a world record. Actually, she holds the world record for the most piercing. I just put it up there, 4,225 times. So let alone when we in medical practice, you guys, I remember one of the students came to me and she was scared to prick herself in the blood lab. So can you imagine there's one scenario and the other scenario is it become a fashion, a cult behavior, a sociopath. There are many terms people are still working on it, but that's for real. Now, based upon what we teach you, regardless of how sterile the needle prick is, regardless of whatever is going on, you have to keep in mind that you are opening a hole on your skin or mucous membrane for all those lovely friends of yours that we've been teaching you. Okay? So next time, if you are in that scenario where people are going to come and advise you, right? So you have to be careful of what advice, and it should be based upon whatever we tell you. Sorry for you can't read it, I'll read it for you. I was reading for you, they said that yesterday's paper, or day before yesterday, that especially for the oral piercing, the maximum number of bacteria human beings have is oral cavity. And there's nothing you can do about that. Maximum number of bacteria you have in oral cavity. And if you happen to have piercing in the oral cavity, right, it can lead to infections of the heart. In this case, is a report infective endocarditis, where the infection, because the thing is this, that hole is going to be patent at all times. And you cannot, no matter how many times you rinse your mouth or you whatever you want to do, nothing is going to happen. Those bacteria will stay. So these are some piercing that have become endowment, fashion, cult, for so many reasons. But on the other extreme, there is extreme piercing. So you can see people sometimes today, let alone with the minor piercing, so they have extreme piercing. And if you were to interview people who pierce different parts of their body, and if you ask them, there is I wouldn't say any medical term for that, but something psychologically involved. They feel good about that. They enjoy it. It's like more of whatever. But the point is, whether it's small or big, you have to keep in mind, your body doesn't like it. It's non-physiological. I can tell you right now, I taught you physiology. It's non-physiological. You will definitely have inflammation. You see, you'll definitely have inflammation. You have chronic inflammation. You have all these things that are going to land you in trouble for sure. Okay, I'm sorry? Say it again? Yes. But the point is, I'm just trying to overemphasize the point from the dormant piercing that people have on skin and mucous membrane, right? And as I told you, no part of body was exempt from there to like medical reasoning. Why should you have that? When we just told you that it's serious. Now, this is a typical facial spasm we call rhizus sardonicus, as if he was laughing, but actually it is a facial spasm with the tetanus of this patient. And I mean, I will tell you my own story. I myself, when I was rotating in medical ward, and I mean, it was like such an experience. If you were to see it, it's very, very challenging. This young boy over here, this is not the one that I've been talking about, but it's very common, who got tetanus, and you can actually see the breaking, you can hear the noise of breaking bones. contraction. Breaking bones, I mean, it's very difficult for you to actually see that, right? And the problem is if that contraction set in, it's not going to allow you to come near it. You can't even give an injection. Very, very, very disturbing. I mean, correct. So this is a very severe, and if you look at classic history, it's a classic historical picture from the medical books that even if you're that smart and that strong, this can break your back into two. This is called tetanus span. That was a horrifying thing even in today's medicine, where they say that that spasm, of course, the problem, they die because the lungs, respiratory muscle go in spasm. You can't put the ventilator. That's what they die for. But if you were to look at this situation, this is very scary. So tetanus is a major threat. We diagnose it based upon clinical presentation, and I gave you an idea. If you look at the microscopy, you can you're not really figure out, but we usually go for the tetanus toxins or antibodies that we detect. So more of microscopy and culture are insensitive, so you can't really pick them up. Number one, and then you cannot pick up which particular kind of clostridia are we talking about. But this one is for the tetanus, the one that you got for a roadside accident. So you have to be careful. Yeah.
What about that one that's in cans, like open cans of food?
Just wait. Just give me a couple of minutes. I'm going to come to that. Okay. How do you treat it? Again, surgical debridement, antibiotic therapy, passive immunization, antitoxin globulin, and vaccine with tetanus toxoid. As I said, booster doses every 10 years. If you have not, good for you to have one. Okay. The one you are talking about is Clostridium botulinum. So that's another Clostridium. And again, it has another toxin. Now, this toxin is called botulinum toxin, right? This consists of 7 distinct toxins from A to G, right? They prevent release of acetylcholine and thus block neurotransmitter. So the paralysis that you have in this case will be flaccid paralysis as compared to spasmodic paralysis. You want to give it to me? If you're done? Yeah. Because, I mean, attendance is not mandatory. But what I would do is that, I mean, I already sent an email to a couple of you. It's not mandatory. And even if you skip, it's good, no problem with me. But if you sign for somebody else, this is a serious ethical problem that's going to go to your portfolio. Right? You may do good to whosoever you want to do good, but both of you, the one whose name is signed and the one who signs it, especially for a class where attendance is not mandatory. And unfortunately, I mean, it's very obvious. I mean, I look at you, it may seem to you that I don't know your names, but many times I do. And I can figure out who's coming in and out. It's so obvious. I have to come every day. So please don't put yourself into a trouble unnecessarily. There's no points associated with it. The only thing is that's for my own research. I want to figure out if people are getting benefit that they need to get benefit from. Okay, thank you. So flaccid paralysis. The question usually asked is the difference between Clostridium botulinum, and now you remember when I told you Botox. So this was where, because if I have wrinkles, I don't want tetanus toxin over there. It's going to go more wrinkles. I would want to have a botulinum toxin so that it relaxes. So muscle, because you get that kind of wrinkles because of contraction, so you relax them. So you need that Botox. Botox is coming from that bacteria causing flaccid paralysis. Again, it's present everywhere. We normally see very few cases, but very prevalent in developing country. We do have a problem, infant botulism. And next time, I must have told you in physio as well, next time you go and buy yourself a jar of honey, you will see over there, it will say tested for Clostridium. It will definitely say that, because nobody can sell any honey in the market if it's not tested by Clostridium botulinum. And they do that as a routine, because that may happen, especially if you want to give honey to the infants. You have to make sure that it's tested for clostridia. Okay, if you look at diseases, again, food-borne botulism, blurred vein, constipation, all these kind of things because of your flaccid paralysis. The key word is flaccid paralysis as compared to paralysis that you get for spasmodic paralysis. Infant botulism, they may get, right, to such an extent you get respiratory arrest. Wound botulism can occur. Inhalation botulism can also occur if you are having, but it has a very high mortality, especially if you inhale that toxin, right? How do you diagnose? As I said earlier, food-borne botulism can only be confirmed if you see that toxin in patient serum fecal gastric fluid. And then what we look for infant botulism is that test for that toxin or the organism in the serum or in the wound. So that pretty much is, we're looking for the toxin that caused damage, because many times remember that bacteria themselves may be less harmful than the toxin they release. But also look at the spin side that not everything is bad about bacteria. The big market, Botox market, is thrive just because this bacteria was producing that particular toxin. How do you treat? These are the treatment of choices: metronidazole and penicillin. And you can also give a antitoxin. You have to give ventilatory support and spore elimination. Again, the idea for us traditionally to put our food in acid pH, high sugar content, or storing it at 4 degrees or colder is because we want to stop spore germination. So if you don't do that, spores of Clostridium botulinum will develop in your food, and then you may get these problems. Toxin is heat label, so this means that if you heat it, so you pretty much will eliminate that. So that's what I mean. So you can those toxins which are heat labile as compared to the non-labile, right? So if you boil something for 10 minutes, you can get rid of it, right? And as I said earlier, especially honey. So you have to be very careful for the kids, especially because honey is kind of, obtained from sources that basically would not be boiled, so to speak. And then they are natural ingredients. So you want to make sure that. The other thing which is more clinically relevant is Clostridium difficile, C. diff. We call it white C. diff. That's very, very important. And in the hospitals, of course, did anybody of you ever work in surgery or have been scrubbed for surgery or nursing for surgery? So you will see that if you were to, you said yes, kind of? Okay. So you can see over there that the way we wash our hands to what the practice of surgical nurses before they put on the glove, you'll be amazed the difference in that. To such an extent, I remember when we were told, we're given that scrub brush over here, right? And you have to wash and scrub each and every nail in all different directions for 10 minutes at least. It's boring. So the nurse over there is going to stand over there, make sure that all the young interns complete 10 minutes. So you can imagine that things are not that simple as we think. You just over there put and these days they think that liquid, done. So especially for the scrubs, because of the dangers that you're going to put that poor patient in that's under anesthesia, and you have no way even for his or her defense as well. So that's very important in terms of scrubbing in. Anyway, Clostridium difficile, it produces two toxins, enterotoxin and cytotoxin. And as I said earlier, all different types of Clostridia are producing different strains. So I'm going to ask you which one is producing which strain. That's the common question asked. enterotoxin, and they are also spore formers. Cytotoxin increases the permeability of the intestinal wall, causes diarrhea, and the same bacteria is responsible for antibiotic resistance, resistant to certain antibiotics like clindamycin, cephalosporin, and fluoroquine. So that is what we think of Clostridium difficile when we think of antibiotic resistance. Now, clinically, when you say what is antibiotic-associated diarrhea, so if you give a person antibiotic and they get diarrhea, so we basically think, especially if you were to give clindamycin, penicillin, cephalosporin, and fluoroquinolones, so you treat the patient for 5 to 10 days, and after that, there's an acute diarrhea, which is called antibiotic-associated diarrhea. Most of the time it's brief and self-limited, but it may not be, right? And I'll explain that to you. The reason is, as a rule, I've been telling you over and over again that your normal commensal flora has set of your friends or whatever the immune system is used to looking at, right? If you replace them or kill them, other bacteria will come, right? Number one. Number two is that each and every commensal bacteria that you have has a fixed quota number of seats. Right? You have this many of this bacteria, this many of this bacteria, this many number of this bacteria. And when you give a broad spectrum antibiotic, it's going to mess up the whole system. So what will happen is one bacteria may outgrow other bacteria. If that happens, especially for the Clostridium difficile, right, it is there and it kind of occupies all the seat. When it does so, it forms a pseudomembranous colitis, right, which is a crampy, abdominal crampy situation with fever. What is plaque? We call pseudomembrane, and you have to look at a colonoscopy in terms of how it looks like. And this is what you can see from here. This is a colon of those people who have antibiotic-associated colitis. Now, that is a plaque that is not a real membrane. It's a membrane on top of your intestinal lumen, intestinal mucosa, and then will be a challenge for us to remove these white clots of fibrin and mucus and inflammatory cells, right? And that is called a antibiotic-associated colitis, typically for Clostridium difficile. If you look at the histological section of the colon, as I said earlier, you will see a black arrow over here. This is a typical plaque, which is overlying the intact intestinal mucosa. This is intestinal mucosa, and then is an HME stain, and you will see that typical plaque over here, characteristic of pseudomembranous colitis. Now, as far as epidemiology is concerned, this particular bacteria colonizes less than 5% of healthy individuals. As I said, that we all may have different microbiome, right? And that's what I think they have developed, NIH has developed, and they are talking about it, and they want to find out what is the normal microbiome of each and every person and how would drugs affect that. So that's something coming up. We are not that far, but they pretty much have figured it out, what is the normal. But for sure, if you give overzealous, especially broad spectrum antibiotics, so you remove those bacteria which are sitting over there, right? So end up having overgrowth of some other bacteria like C. difficile. And this kind of then disease is called endogenous infection, because you just got infected because you gave a chance to C. difficile, which were there in lesser number than now, they have increased the number because of you using antibiotics, overgrowth of bacteria. Spores can be detected in hospital room. Hospitals have to maintain, especially the linen and everything, very carefully. because of the spores of clostridia. And then again, what we are seeing, especially in this country recently, is a highly virulent strain is currently causing problems in hospitals. So this kind of thing, when happens, that we will be helpless. So especially hospitals are designed in a way to be the best places for sanitation and healthcare and so on and so forth. At the same time, bacteria would also employ the worst form of bacteria to be there, because those bacteria may have developed some genetic traits that would outlive or kind of fight off our all standard disinfection, sterility, and whatnot. So that's always a challenge. We call those bacteria nosocomial bacteria, or those infection nosocomial infections. And guess what? All of us, all of you, I should include myself, may be exposed to hospital settings where you go on a daily basis and always get exposed to these microorganisms. Okay, so that also remains a challenge. And these are some of the news that come in microbiology. How do you diagnose it? We detect those toxin, I said, cytotoxin or enterotoxin in patients' feces. Okay, that's what we do. Treatment, prevention, and control. Very simple treatment. Those antibiotics, and I gave you the name of those 4 antibiotics. I'm going to ask you what those antibiotics are. So you have to discontinue using them. Then metronidazole or vancomycin, right? And relapse is common because antibiotics do not kill spores. That's another important thing that he said, that if these bacteria have a capability to form spore, then we may have to go for multiple therapies, and we have all these problems that you come up with. And that's why proper care in the hospital, especially for the fomites, the linen, and all those things, utensils that come in contact with the patient who is having that problem, especially surgical wards. So you can see wound care is important. Okay, now if you look at, this is a master slide, and you can make your own, but I just copied from your book. What you need to do is, again, all those 5, 6 different things that we've been talking over time, and you compare Clostridium perfringens with tetani, with botulism, and difficile, and see where do they mix and match. What are the common features they have? They're all under Clostridium. And what are the drugs that we use? What are specific diseases that they have? What are the toxins they have? And if we do have a vaccine for one or other, right? And what are the epidemiological things that we have? And as I told you, the difference between like the tetanus in terms of having tetanospasmin that blocks the inhibitory GABA or glycine, as compared to botulism, right, which is going to prevent the release of acetylcholine. So all these things are important, compare and contrast. That's what most of the questions usually come for, right? So you want to make sure that you not only understand what clostridial diseases are, but you also can make difference between different types of those diseases. And I just picked up some of the highlight or important things that I think are there. And it's easy. I mean, if I was to ask you pseudomembranous colitis, only difficile will have that. Tetanus is only caused by tetani. And, and the cytotoxin, again, for this one over here, right? And then the tetanus toxide that we have is only for C. tetani. So it's easy. It's not that difficult. But all you need to do is that you have to make sure that you tend to put things in your mind in time. Don't wait till the last minute and try to memorize things in the end. That probably would not work.